Assalamu alaikum. First of all, I would like to express my deepest gratitude to our esteemed speakers. Thank you for joining us this day, and welcome to all our attendants. Thank you very much for joining us. وطبعا special thanks to Dr. محمد نوارة يعني for making this day happen. It's a privilege to know this here. دكتور محمد كان شايف ان اليوفيتس برانش لطيف وخفيف كده وبتاع. طبعا احنا عارفين ان جراحه الشبكيه برضو برانش خفيف ولطيف، فقال لي طب ما تيجي نحطهم على بعض. فيلا بينا نشوف. Introduction سريعه كده. طبعا uveitis is a type of intraocular inflammation that may lead to legal blindness. Though uveitis is mainly medical, can be treated or controlled medically, surgical intervention has, especially because the plan of vitrectomy has a rule in uveitis. طيب, what are the indications for vitrectomy in uveitis? We have two indications, either diagnostic or therapeutic. نبدأ الأول بالdiagnostic vitrectomy. What are the indications? طبعا all the speakers, all the professors have talked about it, either infectious or non-infectious, infectious endophthalmitis, vitritis, retinitis choroiditis, or retinal vasculitis. Non-infectious, autoimmune uveitis, primary intraocular lymphoma, and we talked about it, carcinoma, metastasis, and choroidal melanoma. Actually, Zen Yuzao, 16 studies, he did this study. By the way, the QR code, you can scan the QR code, it will send you directly to the study if you want. 16 studies involving 1,195 patients were finally included. Successful rate of a diagnostic Ppv to diagnose 44% of the unknown cases in uveitis. So maybe diagnostic vitrectomy has a rule after all. So what are the techniques that I can use for this sample, or how can I use this sample? Actually, you have 6 things that you can use. Cytology. You can study the cytology revealing the phenotype of the infiltrating cells. Microbiology, like culture of the media or the isolating causative organism. Histopathology, and actually for histopathology you can divide into 3. You can divide your specimen into 3 specimens. One for routine evaluation, and one frozen in OCT, and this stands for optimal cutting temperature for immunopathological and molecular characterization. And third is for viruses or other microorganisms, or as a tissue culture. This is how we do a histopathology. Another thing you can do with the vitrectomy space is molecular, and mainly to rule out lymphoma. Flow cytometry, and flow cytometry is a centrifuging in the vitreous specimen and resuspension. And the cells after that are counted and stained for antibodies identifying the leukocytes. This is what flow cytometry means, because I didn't know that, so I googled it. واخر حاجه طبعا السايتو والكيموكاينز، ومين احنا بنشوف حاجتين، انترلوكين 10 and interleukin 6. Interleukin 10 for malignancies and interleukin 6 are for inflammatory cells mainly. And again, a study was done by Koichi Uta and found out that in lymphoma, the interleukin 10 to interleukin 6 has to be more than 1. It can be a characteristic to lymphoma. So, how can we collect vitreous? You have 3 methods to collect a vitreous sample. Either a dry, and the dry method, you aspirate while pressing on the globe with the infusion off. You can aspirate safely, maximum 0.5 to 1.2 millis. The studies, I didn't include the study, the QR code will do that. The studies all, except one, said 0.5 milli is safest, but one study that showed 1.2 milli. I would recommend to go for the lower volume and to avoid complications. Second method is pneumatic. By injecting air into the eye, again with the infusion off, you can aspirate up to 1.5 milli can be obtained. Third one is through heavy liquid perfluorocarbon. You can inject perfluorocarbon inside the eye. The problem with this is the sample needs to be frozen afterwards, so you can separate the perfluorocarbon from the sample, and you can collect up to 2.24 milliliter. But don't do what we did first time. Dr. Nawara asked us for a tab. أنا فتحت الانفيوجن على مصراعيها وفرحان جدا إن أنا قاعد بجمع سامبل بقى وفي الآخر طبعا يجيب no results because it was this is for diagnostic vitrectomy. Okay, therapeutic vitrectomy in uveitis, and I apologize and start. Before surgery, what we should know. Vitrectomy can be a safe and effective method in managing wide range of uveitic complications. Some studies, like this one, have suggested that pars plana vitrectomy reduces the overall inflammation activities and improve refractory cystoid macular edema. Actually, another prospective randomized pilot study reported a higher percentage of patients treated with vitrectomy than with immune modulators in resolution early, but not in the visual outcome. So you would expect the patient to be resolved early from the inflammation, but with the same visual outcome. Except for rheumatogenic retinal detachment and infective endophthalmitis, you have, as a rule of thumb, to wait until the disease is quiescent and under medical control. Corticosteroid would be a very good treatment for that. And at the end, we can use, of course, intravitreal triamcinolone or intravitreal antibiotics accordingly for each of their conditions at the end of the surgery to increase or enhance the results of the surgery. Okay, so let's have the shades of uveitis. We start with the first one. It can come in so many shades, like uveitic cases. This is what simple uveitis would seem like. This is a patient, I think it was a young patient, 14 or 15, came and complained from persistent vitritis and persistent diminution of vision. So we tried to do vitrectomy for him. This is a thicket patient, so removing the anterior vitreous phase will be a little bit challenging not to hurt the nucleus, as you can see. And then also because the vitreous, you can see now we are succeeding in doing the BVD with the great wave after a few attempts, the failed attempts. We completed with vitrectomy, Kinacort aided. Again, the Kinacort will highlight the parts that you missed, like this anterior vitreous phase part. We're trying to remove it right now, as you can see. After removing the anterior vitreous phase and do a complete vitrectomy, we try to see what's the cause for this inflammatory process. So while we are indenting to see the periphery, you can see what looks like a reaction, maybe a fibrous membrane, maybe a granuloma, no, because the patient didn't came back, and atrophic holes in the whole periphery of the retina, as you can see here. So because it is a chronic inflammation, we did foveal sparing ILM, and after that we turned into gas and do some laser for the operation, and we finished. Okay, let's dig a little deeper. This is so. I'm sorry. What about an epimacular membrane? Vitritis causing an epimacular membrane. This patient came to us after a failed phaco operation, and he also complained of diminution of vision. He was aphakic, so we started by implanting a 3-piece IOL Yamani technique, and after finishing the Yamani, it went very well actually. And so after that, we went for vitrectomy. Sure. Okay, I think we'll نشوف اليماني تاني عادي. صح، حلوة يعني، وبعدين مشيت كويس، فيعني ممكن نشوفها يعني. شكلنا هنحضر الفرح دكتور نوارة، البرزنتيشن عايزة نحضر الفرح يعني. For our surprise, actually, there was bleeding in, but you can see some surges in the vitreous indicating, I don't know if you can show it, the videos very fast, but you can see the surges in the vitreal cavity indicating some inflammation. After removing this bleeding, we found out an epimacular membrane again, the patient had a chronic inflammation, epimacular membrane on the macula, and there's some peripheral membrane with minute holes, maybe due to manipulation in the first surgery. We didn't know the cause of it, but kinocort aiding after vitrectomy. Sorry, maybe that. Okay. Another case is cyclitic with rheumatoid retinal detachment. This patient came to us complaining of diminution of vision. We thought after removing the cataract, which was easy actually with keratome because it was soft, but we found out there is a membrane, retrointramedullary membrane, that was dense behind this eye. Implanted the 3-piece eye locator. The membrane was very tough that we tried to use the occlutome first, but it didn't eat, so we tried to make a plane by a needle, a 27 gauge needle, and after successfully making the plane, we got into it and tried to dissect it. As you can see, it's really tough, and the occlutome having a hard time trying to eat through it. So after a while, we started just open to do the vitrectomy. We did the Ppv vitrectomy, and you can find superior nasal membrane extending to the anterior segment. Then we tried to remove the membrane from the ciliary body, and this is very important. In intermediate uveitis, when the membrane formed around the ciliary body, it's really mandatory to remove as much as you can, or segment it at least, because the pulling power of it will cause the patient to go into atrophy bulbi after that. So at least try to segment it. Here we did it by manually, and we did debulking to this membrane here in the temporal area, because we couldn't remove it. The scissors couldn't do it, and the occlutome couldn't do it, so we tried to do debulking of it. And with indentation, you try to remove as much membrane from around the ciliary body as you can, as you can see here, to give the patient the chance to bypass the atrophy or the cysts bulbi. This is the O'Malley scissor by Dog, and even it couldn't remove the membrane or couldn't cut it very well, because it was really difficult. After that, we tried to, after dissecting the membrane, of course, the retina has detached because it was actually attached to this membrane, but this is a good sign. It was flattened under BFC. We did laser, and everything went well. So we said cyclitic membrane, retinal detachment. Now we go for tractional retinal detachment. And actually, this patient we had already referred, Dr. Nawar referred him to us. We presumed he was a TP patient, and this is the one that I had the sample from that it's failed. He presented with the left eye tractional retinal detachment, hemorrhagic eye. We did core vitrectomy and then trying to reduce the BVD. Fractional retinal detachment was really difficult in this patient, surprisingly. And tried to do segmentation of the patient and the bleeding, removal of the bleeding, and we switched for bimanual after BFC to protect the macula, because the membrane was actually close to the macula, and it was معلش انا عارف انك اتخضيت هو المنظر اللي كنت فعلا sorry removing the membrane, and after the bleeding we did the PRP. After that we injected silicone in this patient, and as difficult as the operation went, the yielded results was really good. This is the OCT after the operation, and this is the retina after the operation, which is really good. So you have to try the best with your patient to try to get the best results you can, and sometimes it will surprise you. Last but not least, Ppv Uveitis, the most aggressive. This patient was referred to us. She had a corneal bacterial keratitis that developed into endophthalmitis. We did a previous PKB-BBV for her, but then the infection came back again, leading to this conjunctivalization. So after the inflammation subsided, we decided to do another session of penetrating keratoplasty and vitrectomy, just to remove the silicone oil and see if there is something with the retina is good. And actually, the silicone has protected the retina from the secondary inflammation infection. Just membrane, which is a pre-silicone oil membrane, removed. We did laser for the weak parts that you can see, and then we did keratoplasty for hair. Actually, unfortunately, the patient had a stem cell deficiency, so my dear colleague, Dr. Hisham Gharib, decided we will implant stem cells from hair. The patient refused to take it from the other eye, so we took it from the graft itself, and we implanted this stem cells here. The patient is seeing 660 right now. Another case of Ppv In Uveitic, and the last one, I guess. Bardo referred to us, keratoplasty, tectonic graft for infective keratitis over the previous graft, but it developed into endophthalmitis. So we tried to do penetrating keratoplasty with vitrectomy. This one was a really aggressive infection. As you can see, it's really dark in here, and we are trying to go through it. But then suddenly, after a while of core vitrectomy, meticulous core vitrectomy, the disc appeared like a light in a very dark tunnel, which was good. And you can see, of course, the deposits of the infection and the inflammation on the macula. After vitrectomy, this all subsides, by the way, and you have to try your best in these patients. Don't lose hope. Endophthalmitis is not a late stage. Of course, after meticulous vitrectomy, you can cause some iatrogenic tears, especially in the periphery, will be very weak in endophthalmitis. We did laser, again, removing the membrane around the ciliary body, trying to protect the ciliary body as much as we can. But you can see this ciliary body is diseased in this patient. It was affected because she had like 2 keratoplasty surgery. And we removed the keratoplathesis, and we went for keratoplasty afterwards. And that's it. I think this was it. And the patient actually sees right now around best corrected 660. So take home message, try your best for your patient, and surgical vitrectomy has a role in uveitis, and thank you very much.